Yeah, hi guys. Just this is a follow-up video to the uh, two postings done for blood pressure, and this is directed towards students and interns and uh, maybe residents if they're interested. Uh, Managing blood pressure, um, a routine basis or on a clinical basis or on a daily basis. It's a fairly common issue, and it needs to be managed because consequences of not managing um, elevated pressure is there are significant outcomes, adverse outcomes. So that's the main reason to have a basic understanding of how to manage blood pressure. There are probably numerous postings done regarding management of blood pressure, but I'll just give a brief rundown of what is usually done in clinical practice, and you can put this to work in your own lives. And on a general scale or on a statistical scale or on an average, you probably get fairly good results uh, approaching the management in this way. So the approach to follow is what they call step care approach, um, wherein you add a medication, then you maximize the medication, and then you add another medication, and again you maximize the medication, and if required you add a third medication and you maximize the medication with certain other lifestyle changes. The common lifestyle changes that you would recommend are losing weight and reducing the salt intake, reducing the alcohol consumption, and improving the physical activity. So those 3 or 4 lifestyle changes certainly have a bearing on the management of elevated blood pressure. Step care approach is very useful, very important. It's very helpful to the patient, and you have a choice of starting off with a given class of drugs, and people do it in different ways. They may start off with a beta blocker and then add a diuretic, or they may start off with a diuretic and then add a beta blocker. The usual recommendation is to start off with one or the other of this class of compounds, and after you have maximized the dose of the diuretic or the beta blocker, then you add in the next class of compound. The trick there is to add drugs which act on different parts of the blood pressure regulatory mechanism. Like we talked, blood pressure can be controlled by dilating the blood vessels, by reducing cardiac output, by peripheral venous cooling, by reducing the salt content or by increasing the salt excretion, by central mechanisms, by reducing the adrenergic drive, or a combination of all of these. And the drugs that are commonly used work in one way or in a combination of ways in these processes, in these pathophysiologic or rather physiologic processes to regulate your blood pressure. Usual recommendation would be to start off with a diuretic because they have been around a long time, they are safe. Something like hydrochlorothiazide. There are multiple drugs in the diuretic class, but HCTZ is most commonly used. You can pick some diuretic that you are familiar with. Our recommendation would be to use a diuretic that does not necessarily work on the loop of Henle or the loop diuretics. The reason to do that is because loop diuretics help with acute reduction of blood pressure and have a slightly more potent impact on the solute excretion because they act on the loop of Henle, if you remember your renal physiology. I would encourage you to go through the mechanisms where these drugs work and how they work to understand their physiologic effects. This is just a clinical talk. So to start off, recommendation would be to use diuretics like hydrochlorothiazide, preferable not to use a loop diuretic. And say you do hydrochlorothiazide, and that's step 1. And you start off with a dose given for the body weight. Usually if it's an adult patient, you would start off with something like, say, 25 milligrams. And I'm just quoting hydrochlorothiazide because that's something that most people are familiar with. And after that, you maximize it to 37.5 and then to 50 milligrams. And then you see what the pressure readings are. If they are not regulated, then the next step would be you add beta blocker. And again, you have a choice of beta blockers. And in our clinical lives, we cannot be familiar with 6 or 7 drugs from each class. So you can choose 1 or 2 that you are familiar with. Get yourself familiar with, and the common beta blockers are atenolol and metoprolol. Just a word of caution or suggestion here that many times the drugs are in combination, and they are hydrochlorothiazide in combination with atenolol, or beta blocker and an ACE inhibitor. They are all in combination. It's a little difficult to maximize the dose or to see if there are any adverse effects when you use combination tablets. It's sometimes cheaper for the patient, and they are well marketed because of the ease of administration, but they are not the easiest to manage, because when you do step care or when you do the stepped approach, you cannot gradually go on increasing the dose, because if you increase the dose of the beta blocker, you disproportionately increase the dose of the ACE inhibitor if it's a combination pill. So that's something to keep in mind when you're trying to adjust the medication. So the step 2 would be you add a beta blocker, and you have choice. Again, you can use atenolol, metoprolol. Some people use labetalol, and you have to be careful with the combination pill. And labetalol, again, it works both on alpha and beta receptors. So that's something, again, one has to be familiar with the mechanism, which is why I suggested that you look up the physiologic mechanisms by which the blood pressure pills work. Now, after you have added the beta blocker, again, say you have added metoprolol. So you started off with 25 milligrams, and you can go on increasing the maximal dose, and you could increase gradually till you reach 100 milligrams or something like that twice a day. Some people can use higher doses also, but I think 100 milligrams twice a day is a fair trial. In addition to all the lifestyle modifications that I mentioned. If that doesn't work, then step 3. Now you maximize the diuretic, you maximize the beta blocker, now you're going to maximize the step 3 drug, and usual recommendation would be adding in an ACE inhibitor. Again, there's a choice between the ACE inhibitors, and you can do enalapril, lisinopril, captopril. You familiarize yourself with 2 or 3 of these. The usual prescription would be for enalapril or lisinopril. Enalapril is, you can gradually increase, it's got more flexibility to increase the dose. You start off with 2.5 or 1.25 milligrams, and you can gradually go on increasing it till the pressure readings are well regulated. So that's step 3. After step 3, it is still not regulated. Now you go to step 4, and the choice there would be adding drugs that work in other mechanisms. And now you're talking about drugs like clonidine or alpha blockers, doxazosine. And there's a whole different class of drugs that are available. You could add drugs like losartan and valsartan. They are similar or improvements of the ACE inhibitor, but that would go into, actually that would go into step 3, depending on the response to the blood pressure and the side effect profile. In step 4, you have added drugs like, say, clonidine. You could add the doxazosine, not sure if I spelled that right, but doesn't matter. That's an alpha blocker, and that usually would get you the required result. And the point of the conversation is that you want to do this in a stepped way. You want to maximize the dose as you go along, and you make sure that there is compliance. Because many times these drugs have to be taken daily, they have to be taken once or twice a day, and if it's not a combination pill, then the patient is going to take them at different times in the day. And if he's going to take 4 drugs or 5 drugs just to control his blood pressure, it's very confusing for the patient to keep all the drugs in sync and take them at the right time unless the patient is very motivated and understands what he's doing. So, compliance can be an issue with this kind of a situation, especially something that he or she has to do on an everyday basis. But, it does depend upon your communication with the patient, the emphasis on compliance, the simplicity of the regime. One thing for the simplicity of the regime does mean that when you gradually maximize the drug, and if you can get done with 1 or 2 drugs, it's a lot simpler regime than doing hit or miss treatment with multiple drugs, not getting the desired result. So you can figure out which prescription medication is suitable for your purpose and be familiar with 1 or 2 or 3 of them from each class, and use them with gradual dose maximization. You do have to pay attention to common side effects that you would experience at each of these levels. Step 4, well, I will just make one other point here. Step 3, you can also add a calcium channel blocker. That would be drugs like amlodipine. That's the most common calcium channel that is blocker that's used. Diltiazem is the other one that also is used. Verapamil is another one. For some reason, diltiazem and verapamil are used more frequently for rhythm control and in an acute setting. That doesn't mean you can't use them for blood pressure issues. You can, but it's a question of what you are familiar with and what you feel comfortable using. So I'm not a drug rep, and neither am I making any recommendations about writing a particular brand or anything like that. But this is a logical approach to treating and managing somebody's blood pressure with the simplest regime, with gradual dose maximization. And you have a choice of methods to use from the different classes. What does help is being familiar with the drugs and looking up the mechanism, because all of these work in different ways and at different points in the blood pressure tree or in the blood pressure mechanism. Last point to make here is we are not talking about blood pressure and related emergencies. The point of the matter is that you don't want to get to a blood pressure or hypertensive emergency or a hypertensive crisis. You just want to deal with a patient who is walking around and sees you in an ambulatory or a routine situation wherein he has isolated blood pressure, elevated readings, wherein you do the appropriate treatment protocol and get his pressure well regulated. Hypertensive urgencies and emergencies are a different subject. The triage is different. Patient will not see you in a routine outpatient or an ambulatory setting. Usually it would be in the emergency room or in the hospital setting. We can refer to the other 2 conversations that we have had about blood pressure to some extent to approach those variables when you are dealing with blood pressure and its management. Alright, so the takeaway would be blood pressure management is very important. I can assure you that you will deal with it on a very routine and a regular basis, given that the consequences are fairly widespread and on a short-term basis and on a long-term basis and on an ongoing basis. It's very important to have the appropriate approach and be familiar with the drugs and the physiologic effects. And it's a good place to start dealing with cardiovascular physiology, because when you deal with the drugs and the effects, you become very familiar with the cardiovascular system. Lifestyle management is very important. That being said, the weight loss, salt intake, alcohol consumption, physical activity is very important. It is not clear if smoking affects blood pressure or not. In regular clinical experience, blood pressure does not get affected that much by smoking. But that does not mean that the patient should go on smoking, but that's a separate issue. And combination of these drugs with appropriate dosages and preferably avoiding combination pills will help you dealing with blood pressure at our level, and you will confer a lot of benefit to a lot of people, and it really is a urgently addressable, easily addressable public health issue which requires everybody's attention, especially people who are clinically dealing with this on a daily basis. Right? Thanks very much for listening.